Welcome to this masterclass on alcohol withdrawal, focusing on symptoms and pharmacology. I'm Mr. Nagesh Sir, and this video is brought to you by ND Nursing Coaching. Let's begin with a pathophysiology multiple choice question. Chronic alcohol consumption leads to a neurochemical imbalance. What happens to the neurotransmitter receptors after sudden cessation of alcohol? The correct answer is B. Alcohol is a CNS depressant that enhances GABA, an inhibitory neurotransmitter, and inhibits NMDA, which is excitatory. Upon withdrawal, GABA activity drops and NMDA receptors upregulate, leading to CNS overstimulation. Moving to the withdrawal timeline, a patient with a long history of heavy alcohol intake is admitted. When does the nurse expect the minor withdrawal symptoms to peak? The correct answer is B, 6 to 12 hours. Minor withdrawal, or autonomic hyperactivity, starts as early as 6 to 12 hours after the last drink, presenting as anxiety, tremors, insomnia, and GI upset. This timeline is critical for exams. For our next clinical presentation question, a patient reports seeing, quote, insects crawling on the wall 18 hours after cessation of alcohol, but is otherwise oriented. What is this condition? The correct answer is B, alcoholic hallucinosis. This typically occurs 12 to 24 hours after cessation. The key feature is a clear sensorium. The patient is oriented, unlike in delirium tremens, where consciousness is clouded. Focusing on seizures. Rum fits or withdrawal seizures typically occur within what period after the last consumption? The correct answer is C, 24 to 48 hours. Withdrawal seizures are generally generalized tonic-clonic. Nursing priority during this 24 to 48 hour window includes seizure precautions and aggressive treatment with benzodiazepines. Now concerning delirium tremens, which of the following is the most life-threatening complication of alcohol withdrawal, usually occurring 48 to 96 hours later? The correct answer is C, delirium tremens, or DTs. This is a medical emergency with high mortality, typically peaking at 48 to 96 hours. Symptoms include severe agitation, autonomic instability, and global confusion. In diagnosis and assessment, a key clinical differentiator between alcoholic hallucinosis and delirium tremens is the presence of which symptom? The correct answer is C, clouding of consciousness. Disorientation is the hallmark of delirium tremens. In hallucinosis, the patient is fully oriented and generally aware the hallucinations are not real. Regarding the drug of choice, what is the, quote, standard class of drugs used for the management of acute alcohol withdrawal symptoms? The correct answer is C, benzodiazepines or BZDs. These are cross-tolerant with alcohol and stimulate GABA receptors, substituting for the missing alcohol. They prevent seizures in DTs, with chlordiazepoxide and diazepam being common. Focusing on pharmacology, which benzodiazepine is typically preferred for a long-term detox program due to its long half-life and smooth tapering? The correct answer is C, chlordiazepoxide or Librium. This classic drug of choice for alcohol withdrawal has a long half-life, providing a self-tapering effect and effectively reducing the risk of rebound symptoms and withdrawal seizures. Considering liver considerations, a patient with alcoholic liver cirrhosis and elevated liver enzymes is experiencing withdrawal. Which drug is safest to use? The correct answer is C, lorazepam. In liver failure, use the LOT drugs, lorazepam, oxazepam, and temazepam. These are metabolized via glucuronidation, which remains intact in liver disease, unlike other BZDs. Which standardized tool does the nurse use to assess the severity of alcohol withdrawal and determine the need for medication? The correct answer is C, the CIWAAR scale. This scale assesses 10 symptoms and uses the score to guide benzodiazepine dosing following a symptom-triggered protocol. A score of 8 or more often indicates a need for medication. Next, let's consider vitamin B1. Why is vitamin B1, thiamine administration, a critical step, which must occur before IV dextrose administration in patients with alcohol withdrawal? The correct answer is D. Thiamine is a cofactor needed for glucose metabolism. Giving dextrose without thiamine can deplete the remaining thiamine stores, triggering or worsening Wernicke's encephalopathy. Focusing on the Wernicke's triad, which set of symptoms constitutes the classic triad of Wernicke's encephalopathy, a severe complication of thiamine deficiency? The correct answer is A. The classic triad includes oculomotor dysfunction, ataxia, and confusion. Treatment involves immediate high-dose parenteral thiamine to prevent progression to Korsakoff psychosis. Looking at chronic complications, Which condition is a chronic, irreversible neurocognitive disorder that is the late stage of thiamine deficiency following untreated Wernicke's encephalopathy? The correct answer is C. Korsakoff psychosis. This is characterized by profound, irreversible memory impairment and the inability to form new memories. It is often referred to as Wernicke-Korsakoff syndrome. What is the hallmark symptom of Korsakoff psychosis, where the patient unconsciously fabricates detailed but false memories to fill in gaps caused by severe amnesia? The correct answer is B. Confabulation. Confabulation is an unconscious process that helps the patient maintain social connection, but it should not be confused with intentional lying. It's a key feature of Korsakoff syndrome. Considering adjunctive therapy, what electrolyte is often depleted in alcohol-dependent individuals and is often administered to help decrease the risk of seizures and arrhythmias during withdrawal? The correct answer is D. Magnesium. Hypomagnesemia is common and can contribute to hyperexcitability and seizures. Magnesium is often administered alongside thiamine and benzodiazepines. Regarding the clinical sequence, in a patient experiencing acute alcohol withdrawal, what is the correct order of medical interventions? The correct answer is A. The sequence is thiamine first, followed by benzodiazepines, and then IV dextrose. Thiamine must precede dextrose to prevent Wernicke's encephalopathy. Moving to aversion therapy. Which drug works by inducing an unpleasant physical reaction, such as severe nausea and vomiting, when alcohol is consumed? The correct answer is B. Disulfiram, marketed as Antabuse. This drug is used for aversion therapy, creating an acutely uncomfortable reaction if alcohol is ingested. How does disulfiram exert its therapeutic effect in aversion therapy? The correct answer is A. Disulfiram inhibits acetaldehyde dehydrogenase, leading to a toxic buildup of acetaldehyde when alcohol is consumed. This results in the unpleasant reaction. Focusing on patient education for disulfiram, what is the most critical education point the nurse must provide to a patient starting disulfiram therapy? The correct answer is C. The patient must avoid all forms of alcohol, including mouthwashes, cough syrups, and aftershaves, as even topical or hidden alcohol can cause the severe reaction. Finally, concerning anti-craving drugs, which two medications are primarily used for reducing the craving and maintaining abstinence after detoxification? The correct answer is B. Naltrexone and acamprosate. These are the two primary medications used to reduce cravings and support long-term sobriety. Let's explore naltrexone. Naltrexone reduces alcohol cravings by blocking which specific receptor system in the brain? The correct answer is C. Mu-opioid receptors. Alcohol consumption releases endorphins, which bind to these receptors, creating euphoria. Naltrexone blocks this reinforcing reward pathway. Considering naltrexone's rationale, naltrexone works to reduce craving by blocking the reward pathway, specifically the feeling of pleasure that alcohol provides. This slide summarizes the naltrexone rationale. Now, the second key anti-craving agent is acamprosate. This drug works by modulating which primary excitatory neurotransmitter?